Hey everyone, welcome to the EMS Academy training series. For those who I haven't met, my name is Sean Barinholtz. I am an anesthesia and ICU physician at Hopkins. I'm an active member of Pikesville Volunteer Fire Company in Baltimore County, and I have the honor of serving as one of the associate medical directors for Baltimore County Fire Department. On behalf of Dr. Andy Pollack in the medical director's office, on behalf of the EMS office, Chief Nats, EMS Training Academy staff, and Captain Lenny Stewart, and Chief Utz, Jen Utz, who's with us tonight. Thanks for joining. Thank you for what you guys do. Thank you for your dedication to lifelong learning. Big shout out to Nikki Austin, who's also a member of Pikesville and Department of Nursing at Towson. Nikki is the one who brought us our speaker tonight. Thank you for that. And also a big shout out to Ashley Brooks, another young member and volunteer of Pikesville, who's helping us run our Zoom platform. Ashley's also the one who helps us with our CEU link. Later in this presentation, Ashley will be putting a link in the chat. Click on the link, enter information, get your MIM CEUs. If you have questions about your MIM CEUs, if you can't navigate the link or have difficulty navigating the link, or have questions about how to see your transcript from MIMS for your past year of training or classes that you've participated in, please feel free to stay with us after the training tonight. Ashley and I will hang out and make sure that we've answered your questions. So super excited to have with us tonight Dr. Briana Snyder. Dr. Snyder is an assistant professor and graduate program director in the Department of Nursing at Towson University, where she has worked since 2016. She is a board-certified psychiatric mental health nurse. She has maintained clinical practice on the inpatient trauma disorders unit at Sheppard Pratt Hospital in Towson since 2009. Her area of expertise and research focuses on the care of individuals diagnosed with dissociative disorders and other trauma-related disorders. Briana, thank you for being with us tonight. Thanks for what you do, and thanks for sharing this with us. We super appreciate you.
Sure. Thank you so much for having me. And thank you for the wonderful introduction. So good evening, everybody. Thank you so much for taking time out of your day to be here, whether you're at the end of your day or the beginning of your day or somewhere in the middle. I appreciate your time. So I hope to share some interesting and helpful information with you tonight. As I was saying to Dr. Barinholtz earlier, I have a really informal style, so please feel free to ask questions, to interrupt me. You can unmute, you can use the chat, whatever works best for you. I welcome that. So as Dr. Barinholtz said, my main role is as an assistant professor at Towson University in the Department of Nursing. So I primarily teach psychiatric mental health nursing to undergraduate nursing students and graduate nursing students. And I've been a nurse since 2009. My whole career as a nurse, I've been at Sheppard Pratt Hospital, right next door to Towson. And I ended up on the trauma disorders unit there completely out of luck. So when I was chit-chatting before we started this recording, I was saying that I did my practicum when I was getting ready to leave nursing school in the emergency department. And I thought for sure I was going to do some kind of critical care, like emergency nursing or ICU nursing. But at the time, they weren't hiring new grads in those roles, and I needed a job. So I was like, well, psych was pretty cool. Maybe I'll try that. So I had done my clinical rotation at Sheppard Pratt Hospital and loved it. So I applied to a few units there. And the first one that called me was the trauma disorders unit. And I just fell in love with the patient population. And that's what I've done ever since. So I still work there as a per diem registered nurse. That's my research focus, and I could talk about it forever. So I will try and keep it focused and short and meaningful for you all tonight. So again, please feel free to ask questions and interrupt me and all that good stuff. All right, so I'm going to share my screen here. I won't be able to see you, and it's difficult to see the chat. So I don't mean to ignore anybody. Please feel free, like I said, to interrupt me. All right.
Well, let's put things in the chat, and I'll keep an eye on the chat for you guys.
Okay, perfect. Thank you so much.
Yeah, of course.
All right. All right. Here we go. Okay, it looks like it's in presentation mode for me. Does it look like that for you all?
Perfect.
Absolutely. Okay, cool. Good deal. All right. So, just to start off, we're gonna just center ourselves for a moment here. I should have also mentioned that in addition to being a nurse and a professor, I'm a yoga teacher and a Reiki master. So I'm all about being mindful and taking a moment to center and ground and realize where we are and what we're doing. So no matter where you are, if you're at home, if you're at work, if you're sitting in a parking lot waiting for your kid to get out of practice, just take a moment to ground yourself. So this is a strategy that we use with patients with dissociative disorders, but it just works really well for anybody. So it's called 5-4-3-2-1. You may have heard it before, but basically it works you through the 5 senses and makes you focus on the present. So all of those things swirling around in your brain, your to-do list, your grocery list, you know, whatever crises you have going on at work, or maybe problems with family members or whatever it is, just kindly say, thank you, brain. We're going to put that aside for a minute. All right. So 5 is 5 things you can see. So take a look around your space and name 5 things you can see. And when we do this with patients, we have them do it out loud. So it works a little better, but you certainly don't have to do that now, but you're welcome to. So, you know, refrigerator, table, pen, laptop, you know, name 5 things that you can see from where you're sitting. Okay. And the more descriptive you can be, the better, like blue car, brown dog, you know, whatever it is. Next, 4 things that you can touch. So don't forget, this isn't just with your hands, this is with your entire body. So feel the seat that you're sitting on. Is it soft? Is it hard? Is it comfortable? Feel the ground underneath your feet. You can dig your toes into the carpet. Anything you can touch. Maybe you have something you're fiddling with, a pen or some keys or something like that. Next, 3 things that you can hear from where you're sitting. So you probably hear my voice, and that's one that we use for grounding a lot when we're working with patients. Maybe there's some music playing, maybe the TV's on in the background, maybe you have a family member who's being noisy nearby. Okay, but 3 things that you can hear. And then 2 is 2 things you can smell. So maybe you have dinner cooking, or maybe you're eating dinner if you're lucky. So maybe you have something cooking, maybe you have a candle that smells nice that's lit nearby. Maybe you just put lotion or hand sanitizer on your hands that smells good. But 2 things that you can smell from where you're sitting. And then finally, 1 thing you can taste. So if you're eating dinner, good for you. Enjoy it. Think about the flavors that you're experiencing. Maybe you're chewing gum, maybe you're having an adult beverage, whatever it is. What taste are you experiencing? A lot of times when we work with folks with dissociative disorders in the hospital, they'll use like a strong peppermint or gum or some kind of, you know, sugary drink like juice that has a strong flavor that can be really grounding for folks. All right. So I will tell you more about why we're doing that in just a minute, but it's a nice thing to use if you're feeling overwhelmed at any point in life, at work, at home, wherever it ends up being. All right. So every good presentation has objectives, right? So hopefully by the end of this, you will be able to talk about the causes of dissociative disorders and what it looks like, the signs and symptoms, as well as some concrete strategies for how you can manage these intrusive symptoms that folks experience and ways that you can help them. So I'm going to come out of this real quick and we're going to do a quick poll here. So I don't know if folks have used Poll Anywhere before, but I'm going to put a link in the chat and it's anonymous. Let's see, copy link. All right. So you should see a link in the chat there for a quick poll. And the question that I want to know is, have you interacted with anybody diagnosed with a dissociative disorder so far in your career? And I'm going to share this screen so hopefully you can see your peers as they respond. All right, got a couple coming in. We have a lot for yes. I love this. Well, please chime in. I'm going to call on you. All right. Anybody else? It looks like we're not moving anymore at the moment. All right, so a lot of folks say yes. That's awesome. That's amazing. And that makes perfect sense given the prevalence, which we'll talk about in a minute. If you haven't or you're not sure, no worries. We're going to talk about it. Oh, there's a few more. Okay, great. All right, let me go back to my PowerPoint here. All right. Oh, sorry. Did somebody say something?
No, I think it's just a
Oh.
background noise.
Okay, got it. Didn't want to ignore anybody. All right, so continuing with my windshield survey here, just to get a sense of the audience here. We're going to do a quick Jamboard with some sticky notes. So I'll show you what that looks like. So basically, I want to know what you have heard about dissociative disorders or what you think about dissociative disorders. These could be personal opinions or thoughts of your own. These could be things that you've heard or things that you've heard other people say, things like that. So let me share this Jamboard with you and show you how this works if you've never used one before. So hopefully you see like a little blank grid here. So what you do is you're going to come over here on the left and there's a little sticky note button. So click on a sticky note. You can choose your color if you would like, type your message and hit save. And your sticky note will pop up on the screen for everybody to see. You can add as many as you want. So feel free to, like I said, add things that you know about dissociative disorders or things that you've heard or things that you've heard other people say. Okay, let me share this link with you all. In the chat here. And it'll give you a goofy name and an animal. So you're anonymous. We don't know who you are. So whatever you write here, there's no way to trace it back to you. And if you've never used Jamboard, it's kind of a cool platform to use. It's an interesting tool. And as you post, I'm just going to move these around so people can see them. It's just on a Google platform, so it's pretty user-friendly. If you don't want to do a sticky note, there's also an option to add an image if you feel like an image more accurately describes what you know or what you've seen about dissociative disorders. Please do that. Wonder if you have one at times. All right. I wonder if I have one at times if you heard somebody else say it. Anything else that folks know about dissociative disorders or have heard about dissociative disorders? Oh, yes, you can also draw. Whoever's drawing, feel free. Violent behaviors with no recollection following the event associated with past trauma. Okay. These are great. Out of touch with reality, forget things, including who they are. Psychotic symptoms. Oops. Catch-all umbrella term for feeling not yourself and losing touch with reality. Okay. I see one in the chat that says trauma coping mechanisms that can't get the note to show up. Okay. Thank you. Yes. Detachment, usually associated with trauma events. Illogical, altered reality. They forget things, including who they are. Self-harm, absolutely, good one. We'll talk about that too. people with high functioning autism may present with dissociative symptoms in stressful situations. All right.
There's one in the chat, different temperaments that change
Different
frequently. Can't get a post to work in the chat.
Got it. I'm sorry for folks who are having difficulty. Feel free to use the chat. It's really just a brainstorm. Okay, so I think we have a lot of good stuff here. So you all are definitely on the right track. So let's talk about this a little bit. Go back to my slides here. All right, so I'm going to start with some definitions because it can get kind of confusing because it seems like everything starts with the letter D. So you're absolutely right, folks who contributed on the Jamboard. Dissociative disorders and these three things that we're going to talk about here, dissociation, depersonalization, and derealization, are all caused by extreme stress, abuse, neglect, or some kind of traumatic event. So this can be truly anything. It can be a natural disaster. It can be sexual abuse, physical abuse, psychological abuse, domestic violence. It can be things that are witnessed and not even personally experienced. It can be traumatic events that happen over a long period of time repeatedly, or it could be a one-time event. And it's important to keep in mind that trauma is subjective, right? So what one person experiences as traumatic may not be as traumatic to somebody else, right? So there is some subjectivity to it, okay? So dissociation is the underlying factor for all of the disorders, obviously. So there are a lot of definitions out there, but I like this one. It says a state of acute mental decompensation in which certain thoughts, emotions, sensations, or memories are compartmentalized because they're too overwhelming. And the reason that I like that is because it really gets at the fact that the person is experiencing something that is too overwhelming that they can't cope with in that moment. So the dissociation is a coping mechanism. It's protective in that moment. And it works really well, right? Unfortunately, once the traumatic event has passed and perhaps this person is an adult now, it's not adaptive to dissociate, say, while you're driving or while you're at work. So it becomes maladaptive. So what we try to do is help folks learn new ways to cope. We don't ever want to make anybody feel bad for dissociating because like I said, it was a protective thing. It helped in the moment. But now we can help them see that there are perhaps other coping mechanisms that they can use that would be a little bit safer. Because the problem with dissociating is you go away from your environment, basically. So you don't have a good sense of what's going on around you, and you can find yourself in some dangerous situations if you're not fully aware of what's going on. So dissociation, like many things in psych and in life, exists on a continuum, right? So if you think about any time that you've ever driven home and you pull in your driveway and you're like, oh boy, I sure hope I stopped at all those red lights on the way home, because you've done that drive 1,000 times, right? And maybe there was a good song on, maybe you were thinking about things you have to do when you get home, and you just kind of were on autopilot for that drive. So we also call it highway hypnosis, right? That's dissociation, but we don't consider that pathologic. We consider that normal, right? So we have to be able to block out some of what's going on around us. Otherwise, we would be totally overstimulated all the time and we wouldn't be able to focus on anything. So it's not all bad. The other extreme end of the spectrum is pathologic dissociation, which would lead to a disorder. So basically, somebody is dissociating so much or so often that it's causing an impairment in functioning. It's inhibiting their ability to work or go to school or maintain relationships, that kind of thing. So there's a wide range there. And again, just to reiterate, it was a defense mechanism, but eventually it reaches a point where it's maladaptive for folks. We try and help them learn other ways. The other definitions there, depersonalization and derealization, those get at the idea of things not feeling real. So depersonalization is specifically where the person themselves does not feel real. So sometimes it's their whole body, like folks will say, I feel like I'm watching a movie of myself, or I feel like I can see myself from up above and I can see everything that I'm doing. or I feel like I'm walking behind myself and I can see everything before I do it. So those are some of the terms that folks will use to describe that. Sometimes it's just parts of their body. So they'll say things like, I see that these are my hands that I'm typing, but it doesn't feel like my hands. Or I know that I'm walking, but it feels like my feet aren't touching the ground. I feel disconnected. So those are some of the descriptors that people will use. So basically they're feeling pretty numb and detached from what's going on in their physical body. Again, totally a protective thing, right? So for somebody, for example, a child who's being severely abused, that would be a really protective strategy to be able to, have things not feel real or to go away or be able to compartmentalize to be able to survive something like that. Derealization gets at the environment not feeling real. So people will say, I walk into my apartment and I know it's my apartment, but it doesn't feel like mine. It looks foreign or it feels foreign. These don't feel like my possessions, something like that. So it has more to do with the environment. So obviously, these are really distressing things for folks to experience. Okay. So there's often a lot of shame associated with it too. People feel like they're going crazy. They'll say, I think I'm going crazy. So they hide it for a long time. So you may not know exactly what's going on until they start to talk about it. Okay. What somebody looks like when they're experiencing these things can vary. So it can be super subtle. You may never notice, or sometimes you'll see little cues like somebody who will blink really rapidly when they're dissociating, or maybe they have like this wide-eyed look, like a deer in the headlights kind of look and looking very bewildered. So you get more adept at recognizing it when you work with these folks all the time, but it can be pretty individualized and sometimes you can't tell at all without asking somebody or without them telling you. Okay. So, again, super common stuff. It's just when it starts to impair functioning. Oh, I see a question in the chat says, how to get them back to reality? Excellent question. We will talk about that. Hang on. So yes, I was getting ready to say, thinking about first responders specifically and nurses, thinking about, COVID-19 when we were really in the depths of the pandemic and all the things that we were seeing and experiencing, I'd be willing to bet that dissociation was really high in nurses and in first responders because that was a traumatic event for folks, for sure. All right. So now that we have some definitions, what are dissociative disorders? Basically,
Can I clarify super fast?
Sure,
I'm about
sure.
to send you a bit of a lengthier chat. There it is.
Okay.
Can you see that chat?
Yes. All right. It sounds like you're saying a truly traumatic situation that kicks you into dissociation at one time on one occasion has now given you an unknown option in future coping. So a person can now choose to use that method of coping. Is it subconscious? It's not that people choose necessarily. Sometimes they recognize that it's happening and they won't stop it. But when we start to work with people and we teach them skills and things like that, when they recognize it, they have skills that they can use to reground and stop it. But it's not really a choice. It's really the brain, doing something to protect you subconsciously. Yeah, I hope that answers the question. Thank you for that.
Can you close the chat on your screen?
Yep. Okay, sorry about that. How's that?
Yep, just disappeared. Perfect.
All right. So a disorder, by definition, is something that causes an impairment in functioning, like I mentioned, right? So these are folks who have, as it says there, disruption of fundamental aspects of waking consciousness, which would include memory, identity, consciousness, emotion, and perception. So if you have a DSM-5 TR now, a Diagnostic and Statistical Manual of Mental Disorders, these are the 4 that you will see in there under dissociative disorders. And we'll talk a little bit about them. The picture that I have there is the SCID-D. That is the gold standard really for how we diagnose these. So it's a standardized interview that you go through with the patient. If you go through it from beginning to end, it can take a couple hours, but there are abbreviated ways to do it. As you may have heard, Dissociative disorders have sort of a controversial history with their diagnosis, being underdiagnosed, overdiagnosed, misdiagnosed, people faking it, all of these kinds of things. So we don't just, pull this diagnosis out of the air. There are, validated instruments that we use to help us, and the SCID-D is a major one. So in addition to that, we also have really robust research, including fMRI studies showing that folks with dissociative disorders, their brains work differently. So it's really fascinating if you have the time to dig into it. Another misconception is that these are rare. They are not rare. So the prevalence of dissociative disorders is about 10% of the population. So that's 32 million Americans. So that's a huge chunk of the population if you think about it, right? So it certainly doesn't get the same, I would say, publicity as some of the other psychiatric diagnoses. But we'll talk about that as we go on. So I'm not going to say too much about depersonalization and derealization disorder, because we sort of talked about those definitions, and really that's all it entails, is that the primary thing that individual is experiencing are those two things. So not feeling real in their body and their environment not feeling real. And then the other diagnoses that we're going to talk about still include depersonalization and derealization. Those are still symptoms of these other three. So we'll talk a little bit more about them. All right. So first, dissociative amnesia. Has anybody encountered somebody in their work who was experiencing amnesia? You can just pop it in the chat. A yes or no, or not sure. Don't think so. Lots of yeses, no. All right. Okay. All right. So basically, amnesia is the inability to recall important personal information. And this is like above and beyond when you walk into your kitchen and you forget what you came in there for, right? Or you're looking all over for your glasses and they're on top of your head. Amnesia is forgetting like major life events. So the birth of a child, getting married, purchasing a boat, getting a tattoo. So really memorable things, but having amnesia for that. You can also have amnesia for biographical information, like your name and your birthday and where you're from, things like that. And amnesia is not limited to dissociative disorders by any means. What kinds of things can cause amnesia that you know of? Feel free to put in the chat. Stroke, TBI, yep, meds, absolutely. Good, yes. So a variety of things, right? Yep, sepsis, high fevers, dementia, good, good, good. Yes, so like I always say to my students, we always want to rule out the physiological causes first for any psychiatric disorder. We don't want to say, oh, amnesia, you have a dissociative disorder and label somebody like that. So just to be really clear about that, all of these dissociative disorders, if you look in the DSM, come with the caveat that it can't be explained by substance use or by something else going on, okay? Because substance use and many other medical things can cause some of these symptoms. But once they're ruled out and we have a good psychosocial history, it might be that a dissociative disorder is what's going on. Dissociative fugue, these are things that you might hear about in the news from time to time. So that's where somebody ends up in a place and they don't remember how they got there or who they are. And it can be quite distressing, as you might imagine. So, it's somebody who has maybe traveled several states and they don't remember why or where they came from. They don't have any ID, anything like that. So obviously a form of amnesia, very distressing for folks. But you can have dissociative amnesia and not experience a fugue. It's just one symptom that can happen. All right. So has anybody ever encountered, just out of curiosity, anybody like that where they are not able to tell you where they're from or how they got there? Jason Bourne. Yes, that's a perfect example. it's pretty rare. Fugues are pretty rare, but all right. So let's talk about dissociative identity disorder. I'm going to spend a little more time on this one because I think it's probably the most stigmatized and misunderstood. So basically, DID, or dissociative identity disorder, used to be called multiple personality disorder, if that sounds more familiar to you. And basically what happens is it's the most severe manifestation of a dissociative disorder. So these are folks who have experienced extreme severe child maltreatment over a very long period of time, usually starting before age 5. So it's really unusual to see DID diagnosed with somebody with later trauma. Certainly they can have a dissociative disorder, but usually it has to start really early in childhood. Kids can be diagnosed with DID, but it's more likely finally diagnosed in adulthood. It's often misdiagnosed because the symptoms are sort of vague and can be misinterpreted or, viewed as something else. Like common ones would be bipolar disorder or a psychotic disorder. So folks are frequently misdiagnosed, and the average length of time it takes for somebody to be correctly diagnosed with DID is about 7 years. So it takes folks a long time, unfortunately. There are not many providers who specialize in DID, so it's hard to get specialty treatment, especially depending on where you live. We're very fortunate here on the East Coast. We have a lot of trauma services compared with some other places in the country. But, it's something that can be easily missed by a provider. So basically, folks with DID still have those same symptoms we already talked about: the dissociation, the derealization, depersonalization, amnesia. But the hallmark is these distinct personality states. So usually 2 or more, they can have many, like dozens, that take control of somebody's consciousness. They're called many different things. So I have personality states here. A lot of patients will say parts because they experience them as parts of themselves. Another word would be alters or self states. So basically, yes, alters. Thank you. Perfect. So these can vary quite a bit. So parts, I'll use parts for simplicity because that's what we use more often in my work, and it's what most of my patients prefer. But they can have different ages, different genders, different sexualities, different likes and dislikes. They frequently have names. They can have different speech patterns, all kinds of things. And so there is an element of, usually people are kind of fascinated with this diagnosis. It's really interesting to them. And that's understandable. So, it's easy to see how some people could not believe that it's true as well, that it's not a real thing, because it seems like something out of a movie for sure, right? But, it is, again, totally a protective thing. So this is somebody who, as a very young child, was experiencing a traumatic event and was able to, their brain split off at that moment and created a personality state or an alter as a way to cope and kind of hold that memory or that experience of whatever was going on. There's a question in the chat said, is it true that the age of the part is the age when the trauma occurred? It can be frequently, yes. And we'll see that in just a moment here. Good question. Different physiological deficits. I don't know about blindness, but sometimes, yes, like there are patients who will have parts that wear glasses, for example, and others that don't. I've had patients who are vegetarian, and then when their meal comes up from the kitchen, they've ordered chicken fingers, and they're like, I didn't order chicken fingers, I'm vegetarian. And then they're like, oh, wait, somebody inside did, so it's really interesting. And, folks that have this disorder often have a good sense of humor about it. But we just have to be really careful that that humor is not a defense mechanism too, and a way to hide and, that kind of thing. So basically, folks hear voices inside. So how would you distinguish, do you think, between this and somebody who's hearing voices who has schizophrenia? Any ideas what some distinguishing factors might be? Meds, history. It's a tough one, right? So the way that, good, yes, there you go. Don't feel like self. Yeah, okay, good. So there are a lot of nuances there, and obviously you have to do a really careful assessment, right? But the way that folks will explain it is a lot of folks with DID will say that they experience the voices inside, like it's a meeting in there, and they can hear everybody talking inside. Whereas folks who hear voices, a lot of times they can tell you very clearly, like, oh, it's a voice coming from this side of the room, or it's a voice coming from behind me, or it's a voice coming from the electrical socket. So they don't experience it as internally a lot of times, and that kind of thing. So so that's a key difference. Then obviously the history is really important because we don't just base it on the voices alone. Okay. So what we do emphasize to folks though is that they are same brain, same body. Okay. So just because you have parts that sometimes take control of your consciousness, you are still accountable for your actions, right? You're still accountable for your safety and that kind of thing. So we try and reinforce that they are one person. And the goal is to have everybody inside, all of the parts working together collaboratively. When folks get into trouble is when there's not good communication with parts inside. And that's when you find safety issues. You might have a part who holds a lot of traumatic memories and they're very suicidal. And if that person is not conscious of that, they could do some really serious self-harm or a suicide attempt outside of their awareness. Because they didn't know that was going on. They didn't have communication with that part. So it can create some really difficult situations for folks. So when we work with folks in the hospital, we talk about this triphasic model, which is, we think of it like a pyramid. So the bottom is basic safety and stabilization. And that's what we're going to talk about today, just how to keep folks stabilized and safe, at ground level. And then the other stuff happens in therapy. These folks are usually in therapy for years, lifelong even. And it's super helpful for them to be able to integrate, their parts, process some of the trauma when they're ready to do that and all that kind of thing. So that's kind of how we think about it in the hospital sense. So we'll talk about basic safety and stabilization skills today. Unfortunately, it's become kind of popular to fake DID, especially on social media, especially TikTok these days, if anybody's a TikToker or their child is. So that really has made it difficult for folks who are living with this disorder, who already feel a lot and feel a lot of stigma from people who don't feel like it's real or that kind of thing. It makes it very difficult. So quick question for you all. I have some examples there at the bottom, but what have you seen about DID in the media? Or what media have you seen about it? What's your experience been with that? Maybe you recognize the photos at the bottom there. So the one on the left is Three Faces of Eve, United States of Terra in the middle, and then Sybil, of course, which is a rather famous one. So what have you seen about DID in the media? What has been your sense of that? Good, bad, indifferent? Oh, somebody asked, are they hospitalized for years? Generally not, no. All right, Bernardo Castrop. Anything else in the media that you've seen about DID? Any movies or TV shows? Sybil, okay. Yeah, it's often not positive. Mass shootings, right? Unfortunately, anything related to mental illness tends to come up when there are mass shootings. All right. Well, hopefully that means that you haven't seen it, because let me tell you, it's not good. So maybe you've heard of the movie Split, for example. That's one that my students always like to bring up. Or if you watch the Netflix series Ratched, about Nurse Ratched, there was a violent portrayal of a person with DID in that. So there's a lot of stuff out there in the media that reinforces these stereotypes that people with DID are dangerous, and they are not. They are much more likely to be victims of violence than to perpetrate violence. Of course, some do, but it's much more likely to be the opposite. And then the other piece of that is that people expect their symptoms to be really florid and dramatic. Like they expect them to totally change their presentation and their voice and how they're acting every time they switch between these parts. And that's not always the case. These people are experts at hiding. They've spent their whole lives trying to fly under the radar, to avoid abuse and to avoid attention. So often the switches are so subtle that you wouldn't even know unless somebody told you. Certainly they can be obvious. So for example, I've certainly had patients, adult patients who are on my unit talking to me, and then something stressful happens that frightens them and they switch to a child part and they're under the table sucking their thumb. So it can be really dramatic, but that's not the norm, I would say. So folks, these are really dynamic, brilliant, creative folks that have, great jobs and families, and they're funny, and, they're fabulous humans. So they can cope really well, and function really well for a long time until, like any of us, until the stressors build up or the triggers and they need a little bit extra support. Oh yes, Dr. Jekyll, Mr. Hyde. Yeah, good. All right. So the prevalence of DID is about 1% of the population, which is the same as schizophrenia. Although schizophrenia gets a lot more attention, I think, and there's more research about it and gets more funding, but it's about the same. So just something to think about. All right, so I want to next show you a quick video clip. You may have heard of Many Sides of Jane. It came out on A&E a couple years ago. It's one of the better presentations of DID that I've seen. So if you want a more balanced view of what it looks like, I would recommend it. It's still dramatized a little bit, but it's pretty good compared with some of the others. So I'm going to play this for you real quick. It's about 6 minutes long, and hopefully the sound comes on for you too.
Jane Hart is a young mother going public about an often misunderstood condition.
Her doctor diagnosed her with dissociative identity disorder.
It's what we all used to know as multiple personality disorder.
NBC's Joe Fryer got the chance to meet her and learn a little bit more about it. Joe, this is a fascinating one.
Yeah, that's right. Good morning, guys. A new docuseries premieres tonight on A&E Network called Many Sides of Jane. It follows the daily life of the 28-year-old mother. We went to Idaho to spend time with Jane and learn more about the disorder and why she's now sharing her story publicly. Jane Hart is a single mom who's raising 2 boys and learning to live with many identities.
Alexis, Jaden, Madison, Ashley.
She has at least 9 different identities, or as Jane likes to call them, parts.
Yeah, it's Madison, not Jane.
They range in age from 6 to 28 and can appear at any time, typically triggered by stress.
I have secrets to tell you.
Those moments are captured in the new A&E docuseries Many Sides of Jane, which chronicles what it's like to live with dissociative identity disorder, or DID. Jane has lived with the disorder much of her life, but was only diagnosed 3 years ago.
All growing up, I would hear voices and I would hear arguments. It would be like having a committee in your head commenting on everything you're doing. Let's take a picture.
What are some of the things that people say that they get wrong or don't understand about DID?
People immediately assume when you tell them you have DID that you're dangerous.
DID is considered rare. Some studies show it's found in about 1% of the population. Experts say it's often caused by severe trauma during childhood.
The mind becomes compartmentalized as a result of traumatic experience that's almost always emotional and frequently physical and sadly frequently sexual.
Jane says she was abused as a child and now understands that DID helped her cope.
It's a way that the brain walls off those bad memories so that the child can function in day-to-day life and so that they don't have to live with that every day.
One of her parts, Beth, is 10 years old and houses some of Jane's most severe trauma.
And what's your relationship to Jane? I keep bad people away from Janie.
Something especially traumatic happened when I was 10, and that's why she was branched off and split apart from everyone else.
In a lot of ways, your different parts are protecting you, right?
My parts were all created to protect me. Their purpose is to help me and to make life easier. I'm a part of Jane.
I think I'm a little more impulsive than she is, for sure.
But it's not always easy getting all of her parts to work together, and that can impact parenting, jobs, dating, and more.
It's just a matter of us making it day to day and functioning together and really being on the same page, because if we're not, things get they just jump around a lot, I guess.
Is there a stigma about DID that's most hurtful to you?
The stigma that's most hurtful is the parenting one. It's where people assume that you're not a good parent or that you can't handle it. Because it couldn't be farther from the truth.
Can you explain to your kids what DID is?
I tell them I have a unique brain and that mine is just wired a little bit differently than others.
What helps Jane first and foremost is intensive therapy. She goes 3 times a week. She also writes in journals. In fact, different identities have their own journals, and she makes collages.
You know, it's a really good outlet for our creativity, but it's also a way that my parts and I talk to each other and kind of relay messages that we can't otherwise vocalize.
Now Jane is vocalizing in a big way, sharing her story publicly, hoping to raise awareness about DID.
I made a promise to myself when I decided to do this docuseries that I would be 100% real. It takes one person to stand up and talk about it.
Joe, wow. It really is fascinating. Just out of curiosity, did any of her other personalities make an appearance during your interview?
No, not at all. And I even asked her, I said, you know, is there a chance that any other parts would come to the surface during the interview? She said, no, that's highly unlikely because they weren't familiar with me and the crew around us, so they tend not to come out in those settings. So she knew in advance that that was probably not going to happen.
Do they just kind of pop in and out, or do certain experiences and day-to-day activities trigger certain personalities to come out?
Often with DID, it is stress that triggers it, and for her, physically, she usually knows it's happening because she'll actually have a headache, and that's usually what lets her know that it's happening. So in many situations, including hers, stress is usually what can trigger that.
I'm sure a lot of people are wondering this at home. So let's say she's with her kids, and kids obviously can cause stressful situations. Has she ever slipped into the part of a 10-year-old when she's with her children?
Yeah, sometimes obviously the different parts, some of them are younger, will come up while she's with her children, but they all know how to take care of the kids. One of her parts, Madison, is the same age as Jane, 28 years old, and she's very much a caretaker and sort of makes sure that the kids are always taken care of. Jane's always making sure the kids are taken care of. She says they sort of work as a team just to make sure that everyone's sort of on the same page and taking care of the kids.
So, Joe, I understand also for relationships, this has got to be very, very difficult. She, at least as Jane is dating a guy, but one of her parts is a lesbian.
Yeah, that's right. And she talks about that, and this will be explored in the series. But one of her parts is a lesbian, and Jane is not a lesbian. So that does create, you know, some issues that she has to deal with as far as dating and who she can date and those types of things. And in the first episode, they do dip into that a little bit and explore some of the things that pop up because of that.
Wow.
Joe Fryer, Joe, thank you again.
All right. Oh, okay. Sorry, just taking a peek at the chat. So that's a pretty typical presentation of somebody with DID, and you heard some of the things that we've talked about already. So like I said, it's certainly not a perfect portrayal, but it's one of the better ones if you're looking for it. And I think it might be free now on A&E online.
Quite fascinating. If you would like.
There we go. Sorry about that. All right. So what are you going to see on your assessment if you encounter somebody with a dissociative disorder? Certainly you're going to see memory impairment. So that's going to be somebody who has, you know, short-term and long-term memory impairment. A lot of times folks, especially if they had really horrendous maltreatment and abuse in childhood will tell you they don't remember elementary school at all. They have no memory of it. Or it can be short term, like I don't remember, going to work yesterday or something like that. They will also say things like they've lost time or something like that, meaning that they don't remember a portion of their day or several days in some cases. So that's one way that folks will describe it. Disorientation, of course, so folks who don't know where they are or what the date is, what time it is, things like that. Confusion, trancing out, basically meaning appearing dissociated, so that bewildered look, they look like they're kind of zoned out. Folks usually are at one of two ends of a spectrum. They're either emotionally numb or they're completely flooded with emotion. So we do a lot of work with them, helping them experience emotions in a safe way, because historically, usually based on their trauma history, especially if it was, maltreatment by a caregiver or something like that, emotions were not safe, right? So, anger, if somebody was angry, that always meant that somebody got hurt. Or if I was crying and I showed sadness, I got hurt for that. So emotions are very complicated. They have a lot tied in and they're often not safe for people. So they stuff a lot. They stuff those emotions until they kind of become flooded. Or at the other end of the spectrum, they become completely numb and don't feel anything at all, they'll say. You'll see dramatic switches in mood and emotion. So somebody might be, laughing one moment, crying the next moment. A lot of disordered thinking, specifically extremely negative self-talk. So these folks have very low self-esteem. I deserve to get hurt. I deserved the abuse. I'm stupid. I'm not worth anything. So really, really negative thought processes. So we use a lot of CBT, cognitive behavioral therapy, to try to reframe those negative thoughts. This last one here is kind of interesting, non-epileptic seizures or psychogenic seizures. So we'll have folks admitted to our trauma disorders unit, and we'll see that they have a seizure history. And some provider says, oh, you must have epilepsy, that kind of thing. But it turns out what it really is they're experiencing a dissociative episode, and they appear to become unresponsive or trance-like for a period of time, and it can resemble a seizure. So that's something that you might see. Certainly, dissociative disorders go hand in hand with a lot of other disorders. So it's probably a no-brainer that folks would also have PTSD in some cases because of the nature of the trauma. So certainly folks will experience flashbacks, which basically means they're completely re-experiencing things that happened to them in the past. They may think it's 1971 again. And re-experience physical sensations and things as if it's happening all over again. They can also misinterpret their environment. So if there are people in the environment, AKA you as the first responder, they may recognize you as an abuser or somebody's trying to hurt them. So they may, run away from you or try to get away from you, that kind of thing. Nightmares are really common. Really poor sleep hygiene. A lot of the abuse with DID, especially for childhood abuse, is sexual in nature and happened at night. So night times are generally really scary for folks, and nightmares are really problematic. Usually folks are very hypervigilant. So these are not people that you want to come up behind and start talking or come up behind and put your hand on their shoulder. They're going to jump out of their skin. Okay. So they're always looking for danger. Their body's just conditioned to that after years of trauma. So even sitting in a room, you'll notice they'll sit where they can see the door so they can see who's coming in and that kind of thing. So even where they position themselves in space is related to that hypervigilance. Pain is the most common symptom experienced by survivors of childhood maltreatment. And that can be in the form of, old injuries. It can be body memories, which is similar to flashbacks. It's re-experiencing really painful moments. So pain is a really, really common one. Folks will tell you that they're experiencing pain. Sorry, I have the same bullet point in there twice, my fault. And then feelings of shame, guilt, worthlessness, I kind of already talked about that. Other comorbidities beside the PTSD would be eating disorders, anxiety disorders, depressive disorders, substance use, certainly personality disorders. So, if you have somebody who has PTSD, maybe do a little bit extra assessment and see if maybe they have a dissociative disorder going on or something like that. And at the bottom there in all caps, I hope let me go back here. I hope my little chat thing isn't blocking it, but it says self-harm and suicidality. So this can be a very lethal population. I think the last statistic I saw was about 70% of folks with dissociative disorders, specifically mainly those with DID, will attempt suicide as an outpatient. So that's an extraordinarily high number. The self-harm takes a variety of forms. So, cutting, burning, hair pulling, head banging. So you'll see evidence of that on your assessment. It can be to relieve stress. It can be to feel something, because we talked about the emotional numbing. They'll say they don't feel anything at all and they cut just to feel alive or, feel like a human. It can be because things are loud inside in their head. So if they have a lot of parts talking at once, sometimes they will headbang, as in response to that, because it's too overwhelming. Sometimes the self-harm happens outside of their awareness, and that's super distressing to people, right? So if they've dissociated, or if they've switched to a part, if they have DID, and self-harmed, and then they get reoriented and they're like, oh my gosh, I'm bleeding, or oh my gosh, I burned myself horribly. That's really distressing. So, if you're asking them, how did this happen? Like, how did you hurt yourself? They might not be able to tell you, and they're going to be, obviously distressed about it, and that kind of thing. So a suicide assessment and that kind of thing is super important with everybody, but especially with folks like this.
Briana, there are a couple of comments around this slide. Can you take a look?
Sure. Panic attack is a form of a seizure. I guess, are you asking, could a panic attack be interpreted as a seizure? I think it probably could be, depending on, what it looks like. Certainly, panic attacks are really common in this population for sure. That's an interesting question. Tattooing and piercing is a social acceptable form of self-harm. I worked with a psychiatrist who, in his notes in the documentation, would say excessive self-modification. And I always thought that was kind of funny, because it was so subjective. Like, it was excessive to him who had no self-modification, but it might not be to somebody else, right? But certainly, yes, as you saw, Jane said the same thing too. Folks will get piercings and tattoos sometimes out of their awareness. I have had patients say that they will get tattoos to feel something because they feel numb, and so certainly I think they're similar, if that helps. But we don't consider them self-harm, in an assessment sense. So I hope that answered the question. Thank you. That was a great question. The other thing that you're going to see is typically folks who have experienced trauma are fearful of anybody in authority, anybody wearing a uniform, healthcare providers, law enforcement, because typically they haven't had good experiences with these folks, especially if they've disclosed abuse at some point and not been believed. That can be really traumatic, and they will say, I'm never telling anybody again, or that kind of thing. Sometimes, unfortunately, they're abused by people in authority, right? So that could be by a police officer or a priest, a religious figure, something like that. So just by the fact of wearing a uniform as a first responder, that might be really off-putting to somebody. So what we try to do is help orient them to the present, and I'll talk more about this and how we do this in a minute, and help them see that, that look at your face and that you are not their abuser, you are a person they've never met before, and that kind of thing. So we try and do some what we call past versus present to help them see what's really going on in reality. The other thing you might see are really advanced medical issues that haven't gotten treatment because folks are really fearful of going to see a healthcare provider. So it's not uncommon at all to have women, for example, who haven't been to a GYN in decades because of a history of sexual abuse. And it's so triggering for them to go see a GYN, and they might have something really significant going on. Or a dentist, for example, is another good example. So you might, on your assessment, see some health problems that are pretty advanced that haven't gotten treatment because folks are fearful of going to engage with the healthcare system. So what do we do about it? There's no medication to treat dissociative disorders, so we treat the symptoms. So common meds that you might see when you're doing your assessment that folks are prescribed would be anti-anxiety medications like benzos, for example. Antipsychotics, they're sedating, they help with mood stability, they help folks sleep. So Haldol, Seroquel, things like that. Certainly antidepressants, because I talked about the comorbidity with mood disorders, mood stabilizers, lithium, anti-epileptics like Depakote also has a mood stabilization effect. To help people with that lability and that kind of thing. The gold standard is psychotherapy. So you heard in the clip that I showed that Jane goes to therapy, intensive therapy 3 times a week. That's pretty common. So folks are in therapy really long term. I talked about CBT for help with the, interrupting and reframing those automatic negative thoughts. That really negative self-talk. DBT, although it was created for personality disorders, is super helpful in this population in helping with emotion regulation and interpersonal effectiveness, because these folks often will have really poor boundaries, which makes sense, because if you're abused by somebody who's supposed to be your caregiver and is supposed to love you and protect you, and they're hurting you, and they're violating you, there's no sense of boundaries. You never learn that. So that's a lot of what we do with folks. And then electroconvulsive therapy or transcranial magnetic stimulation can be really helpful for folks too, especially with the comorbid mood disorders. Other things that you might see on your assessment because of some of these meds that we use, one that I don't have on this list, I apologize, would be some of the antihypertensives really help with nightmares. So like propranolol, for example, is one that we use quite a bit to help with nightmares. And it can really, as you know, drop folks' blood pressure pretty low and their pulse sometimes. And especially if you have somebody with an eating disorder on top of it, they might be really orthostatic, have a really low blood pressure. So that's something you might see on your assessment as well, based on what they're prescribed. So interventions. Here's what you're going to do, right? Safety is always the #1 priority. Always, always, always. So, assessing for self-harm and suicidality. If somebody is truly in crisis, staying with them or getting them additional support if they need it. What do you know about trauma-informed care? I'm sure you all have had trainings and education on that. What does that mean to you? What is trauma-informed care? Or what are some examples of it? When they're not conscious, okay? Can't spell, it's okay. Spelling doesn't count, it's after 8 p.m. Any other ideas about trauma-informed care? I know I'm asking a lot of you this late in the day. Right. Okay. Yeah, so basically, just like we use universal precautions with body fluids, right? You assume that, somebody's blood is infectious, so you're going to wear gloves or whatever you need to protect yourself. Same thing with trauma. We want to, assume that this person has a background and experiences and perhaps trauma that is influencing their behavior and how they're going to react to things. So we try and be mindful of where folks are coming from and what they might have experienced and how that influences their presentation. So we just want to be really careful with them, right? So it's just kind of trauma-informed care are just nice things to do to other humans, right? So like introduce yourself, say what your role is, Say what you're going to do before you do it. Ask permission. Is it okay to use this arm for your blood pressure? Things like that. Being really careful about physical touch. So, don't touch people without permission. Say, I'm gonna, take a look at your stomach. Is it okay if I lift up your shirt or whatever it is? Anytime you're going to expose somebody, for sure, if you can ask. Obviously, if it's an emergency situation, that's different. But that's always helpful. Reducing stimuli whenever possible. So like things like sirens and flashing lights are really stressful for folks with dissociative disorders, and other people too. So, anything you can do to minimize that, again, not always possible, but just things to think about, that kind of thing. So helping folks reorient to the present. So we did the 5, 4, 3, 2, 1 in the beginning as grounding. That can be super helpful. Our other units at Sheppard kind of tease us because we use frozen oranges, but they work really well because they're cold. So it's a good tactile thing. Folks can dig their fingernails into it if they're really having a hard time and they're having impulses to scratch or self-harm. They have a nice citrusy smell. So that's another sense there that they can use. But if you have an ice pack or something like that, that somebody can use, that can be really grounding and help orient them back to the present and anchor them in what's actually happening. Pointing out things in the environment like you did in your 5, 4, 3, 2, 1, using a calendar or a clock. So if somebody's having a flashback or they're disoriented to the year or the time, show them on your smartphone where it says the date and time, that kind of thing. If you have a badge or something with a photo on it, on the unit, we'll say like, you see my picture here, it says Sheppard Pratt Hospital. You've never met me except here at Sheppard Pratt Hospital. I'm not, somebody from 1984 or whatever it is, that kind of thing. And the patient's own physical appearance. So for example, if somebody's feeling very childlike and somebody who has DID, for example, who's switching to a child part, and they think they're, 10 years old, have them look at their hands. Are those a 10-year-old's hands or are they a 42-year-old's hands? Did you have that wedding ring when you were 10? Did you have that tattoo when you were 10? Things about their physical body to help get them into their body and grounded in the moment can be really helpful. I'm just going to open the chat real quick. Weighted blanket. Yes, absolutely. Our patients love weighted blankets, anything tactile. Yep. Excellent. And then these are things that we do in the hospital for sure, but certainly there are things that you could do as a first responder too. So certainly you could sit with somebody and do deep breathing, right? To help slow things down and destimulate, and that kind of thing. Another super important thing that you want to do, one of your interventions, in addition to your safety assessment, like your suicide assessment and things like that, is find out if they're still in an abusive situation. So folks who have a history of trauma are statistically much more likely to be abused again or traumatized again. So, some of the folks that I work with who have DID, whose abuse started when they were toddlers, are abused well into adulthood by the same family members or the same cult or the same religious organization. They're also more likely to experience intimate partner violence. So assess for that. Human trafficking, assess for that. So, they're much more likely to end up in those type of situations. So part of your intervention should be assessing for those things too. And then keeping in mind, as it said in the document or the clip of the documentary thing that I showed you earlier, folks are very shameful and they're very good at hiding what's going on. So you do have to ask some questions. They're not going to always just come out and say, these are my symptoms, this is what's going on. So it's not as dramatic as we would see, like I said, in the media, movies, things like that. So where can you find more information that's reputable? If you happen to have a DSM, there's great information in there and statistics and things like that. Number one that I would recommend is the International Society for the Study of Trauma and Dissociation. They have really good information that is meant for families, for patients, easily accessible and understandable. And then they have more advanced research stuff too. And then certainly the other links are good as well, for other places to find information. Yes, I will absolutely share this PowerPoint, no problem. And then my last slide here is just some more references. this link at the top, again, this is an article that I wrote for the American Nurse about dissociative disorders. It's written for nurses, but it would apply to just about any healthcare professional. And again, it's written for any level of nursing. So it's meant to be not very technical and kind of layperson. So it's hopefully an easy way to understand it too. And hopefully make sense of some of the stuff that I shared tonight. So that is all I have. I will stop sharing. Thank you again so much. I hope that wasn't too much or too technical or not enough, but I would love to hear your questions, comments, anything that was unclear. Please feel free to let me know.
That was awesome, Briana. Awesome.
Thank you.
My 25 years at this, I've never heard this content.
Well, I'm excited to be able to share it. Thanks. I saw somebody in the chat said any new evidence of hallucinogenic psilocybin might play a role. Yes. Okay. So super exciting. I'm super excited about psilocybin research. I don't know if other people are. There's a lot of good documentaries. Yeah. There's a lot of good documentaries out there about it too. So Hopkins has a psilocybin research center. Sheppard has one. And actually our service chief, like one of my favorite psychiatrists ever, who used to work on our trauma disorders unit, now does research with psilocybin. So she has been doing it with folks with depressive disorders, but getting ready to start with dissociative disorders. So we think that it will have some helpful benefits for our population as well, especially because they have depressive disorders too. So that's a great question. Yes, I'm like on the edge of my seat about this psilocybin stuff. Yes, Colorado did just legalize it. That's true. Oh, you guys are so nice. Thank you so much. Same question.
Ketamine, yes.
Ketamine, yeah. So we actually, I'm sorry, go ahead, Dr. Baron-Holtz.
Oh, that's a great question. Go hit it.
I was just going to say, I have cared for patients who have gotten ketamine therapy and found it really helpful. So again, a work in progress, but yeah, I've seen good things in the folks that I've cared for anyway, that have been treated with ketamine. Let me see. Work with socially and emotionally challenged students in school. Yes, absolutely. So here's the beautiful thing. Kids that are abused, if we can, just like anything, diabetes, cancer, the earlier we can get folks into treatment, the better they do, right? So if we get better at recognizing dissociative symptoms and recognizing, the effects of trauma when kids are young, and we start intervening and doing therapy and removing them from traumatic situations and abusive situations, children are magnificently resilient. Their brains are still growing and changing, and they do so much better than adults do. So if we can intervene earlier, that's really the goal.
Amen.
Anything
Well,
else?
Briana, thank you so much. Thank you. Thanks for being with us tonight. We'll let you get back to your family. We super appreciate you.
Of course.
Yeah, those who want their slides, maybe perhaps email me via the EMS training announcement, and I will work with Briana to get those slides to you.
Sure thing, no problem. I guess I don't think I have my email on the slides. I can do it, but I'll put my email in the chat here. Feel free to email me. I'm a chronic oversharer of information. So it's blsnyder@towson.edu. So I will bore you to death with resources about dissociative disorders. If you want more, feel free to email me.
Awesome. Thank you so much. Have a great night.
Thank you. Take care, everybody.
Bye-bye.